standing, come and assess it laying down as well. So what we have them do, you're going to bring your chin right against your shoulder. Perfect. And then I might be sitting or standing, but I'm going to try to get out of the way. I'm just going to lightly hold her arm, light, relaxed arm here, and I'm just going to assess the internal rotation and where do I hit my resistance, okay? And in theory, those fingers should be able to touch the table, okay? When you come here and internally rotate, you should be able to fully touch the table with the fingers without pushing so hard or hurting the patient, okay? It should just go. When it doesn't go is you've just confirmed your internal rotation deficit. And what we used to think caused that was posterior capsule tightness, but now that's been a little bit disproved through some surgical studies. So you have to think about what else influences this internal rotation moment. And that's where I want to present to you the T-spine and the rib cage, okay? Because this is another kind of a wow factor that you can give patients right then and there. So what we'll have them do is have a slight rotation. They're nice and kind of relaxed. We've got knees up to help kind of balance them. And what we're going to do is we're going to find the xiphoid process of the breastbone, the sternum. We're going to come just off of it to our first rib that we can feel, okay? Now you've got costocartilage there. That's what's connecting the rib to the sternum. So if you push too hard on that cartilage, first of all, you shouldn't even be on the cartilage. If you're on it and you push too hard, you could sublux the rib. If you don't know how to fix a sublux rib, you're in trouble because you just caused a major problem for the client. So the point of this is know your anatomy. Find the xiphoid process, go right down to the rib or the diaphragm, how it meets, and come off of it and make sure you're on rib and not squishy cartilage. Okay, so come off it enough. And then what you're going to do is a thumb over thumb technique, or depending on your hand size, thumb next to thumb, like mine. You have breast tissue to deal with for the females, okay? So we try to go hands really open so that we're not cupping anything. And what we're going to do here is we're just going to very lightly push into the rib, okay? So I'm coming, if you can imagine how the rib is coming around, I'm coming at it like this, right into it, okay? And what I'm going to do is very gently engage it. And I'm just going to oscillate it, very gentle motions. Then I'm going to come up one rib, go through in between the breast tissue, move it out of the way. And for those of you with the guys working with the girls, you can have them do that for you, okay? So that in case you touch, you're touching their hand, okay? And then here I am, I'm going to just go right into her rib very gently because I don't want to create a subluxation. I'm going to go up one more time, off of the sternum, up into the rib. And now we get into a sensitive area. Likely you might hear from them like, oh, that's tender, or that hurts, or if you want to know, ask them. And what you're looking for is to just mobilize these ribs. And do you see how my body is shifting as I'm coming? Because the rib angle is changing as I come up, okay? You okay with that? Did it get a little tender there? A little bit. Not terrible. Good. I'm going to come up again. So now I'm getting really to the top because here's her SC joint. So we know her second rib is going to be right under there. These are the ones you have to be careful that you don't mobilize too hard. We're going to stop around the second rib because we can't touch the first rib. It's too embedded underneath the clavicle. Okay? So we just did the left anterior rib cage. We went from A to P, okay? We do that for a reason. You stay there because we're not done with you. When you have a loss of internal rotation on the right side, that correlates to a trunk rotation to the left. You got me? So that means that it correlates to an external rotation on the opposite side. So she had it on her right side. So that means that she is unable to trunk rotate left, which is why I started her in this position going this way. It's a very simple thing to think about in treatment because I was just here assessing her right side, correct? If I see immediate difference, like I can't get her fingertips down, I know, boom, I'm right in the right position for the treatment. You don't have to think very much. Which side I have to put her on now? And then you're like this, and you're like, you don't need to do that. Because you put her in the right treatment position because you tested her first. You got me? Okay, so now that we've done the anterior, we want to do the posterior aspect. So to create internal rotation, if I'm going to create left trunk rotation, I'm going to push from the back on the right, anterior, PA, from the right side. So I just need her to flip. Okay, you're going to come onto the back side of the table with me a little. Good. Both arms out in front, stacked. Good. We're going to have you reach the top arm a little longer and your hand wraps around that wrist. And she's going to stabilize herself for me. Okay? If they can't get into this position because she's telling me it's pinching here, then we do this. And she can hold her arm for me. Or you can put pillows. You can do any sort of stuff like that. But if she can get there, that's where I'd like her. So now what we're going to do is we're going to find around T7. Okay? I'm going to come over here. And now we're going to find a rib angle. This is a sharp angle on the back side of the trunk. If you come out, you have to think my transverse process is probably deep to the paraspinal, and then I'm going to get to the rib angle. Okay? So we're going to go thumb over thumb or thumb next to thumb, and I'm going to work on her mobility. Okay, so I'm just oscillating into the rib, and then I'm going to go up another one. And what's important to note is that what muscle traverses all the way vertical up here over the rib angles? What long muscle? Lat's there. What's in the spine? Which of your erector spinae? Which one's the most furthest out? Isn't it iliocostalis? Iliocostalis, semispinalis, longissimus, right? So that should have been a giveaway. I'm on the rib, iliocostalis, okay? So iliocostalis can have some really nasty trigger points in it. And if it does, and you hear from them or you feel a twinge from them, like, ooh, that was tender, you just let them know I'm pushing through a muscle that's got some trigger points in it. That's why it feels a little tender to you. And now I'm getting up into her rib. You see, I make her do that to get the scapula out of my way so that I can see her rib angles. Again, I don't push so hard that I'm like trying to manip something. I'm just trying to oscillate it a little bit. I'm going to go up a little higher. Lengthen that top arm a smidge for me. Yeah, good. And now we're right at the tippy top. That's probably a little tender to you, right? Mm-hmm. Yeah, because I'm feeling more resistance now. I got into an area of some resistance. Okay. Good. So now, let's bring you back over this way. same way you were before. You were kind of laying on your, yep, good. Voila. So we're closer. We're like almost there. You see it? So that's a good wow factor. Okay? So that just shows you the influence of the T-spine and rib cage on shoulder mobility. Now, why that's important that we do the front and the back. Under the anterior rib heads here are the ganglia for your sympathetic nervous system. So you're calming her system down as you do this mobilization, okay? So it's really nice to sort of like set the tone to help decrease that overload that her system's already telling you she has. Okay, so now if we have you lay on your back, come a little closer to me, we're going to repeat her nervous system, her upper limb test. Oh, we're getting there, baby. Okay? So that's really nice. So now I might just actually do a few glides. Oops, sorry, I'm pushing on the wrong part of the table. There we go. Good. Okay? So you see how quickly things can change. Scoot that way a little. So now we have to, though, still get into that neuroread piece because her system's not going to know how to hold this. And now I didn't work on her first rib yet, but I just want to see if something changed. It's much better. See that? So that's usually why I don't start in the ribs and shoulder and stuff like that, because there's other pieces that influence. So I start on the thoracic spine and rib cage. I kind of deviated because I showed you her neck stuff first. So spine, let's say C-spine and rib cage go first. They trump everybody. Then we'll work our way into first rib, SC joint. No, I'm going to do scapulothoracic next. Then I'll go check these little guys. What's left in the first rib, what's left in the SC joint, and then lastly is the glenohumeral. I don't even touch the shoulder until the end, because likely you set it all up and all of a sudden things just start moving freer again. So it's spine and ribs, scapula, and then all the little guys. Okay? Does that make sense? Okay, good. Let's see your test standing up.